Usually when you talk about a medical diagnosis, there is this distinct expectation of precision. It feels almost like engineering, you know?
Right, like it should be totally straightforward.
Exactly. Like you break your arm, the x-ray shows that jagged white line in the bone, and the doctor just points to the screen and says, well, there it is. There's the problem.
Yeah, and it's incredibly comforting to have things be visible, to have them easily categorized like that.
It is. But then you step into the world of chronic pelvic pain and vulvar disorders, and suddenly that x-ray machine is just utterly useless.
Oh, totally useless. You're looking at a diagnostic landscape that is incredibly murky.
Right. And patients can spend years, sometimes literally decades, navigating this space. They're constantly being told that everything looks perfectly normal when, in reality, they are in absolute agony.
And that invisibility can be profoundly isolating for you as the patient. I mean, you are experiencing severe localized pain, but the standard diagnostic tools just, they fail to capture the reality of what your body is actually going through.
Which is exactly why today, our mission is to cut right through that diagnostic fog. We're doing a deep dive into the clinical significance of a diagnosis that is highly distressing, frequently misunderstood, and just absolutely crucial to identify if you or someone you love is experiencing chronic tearing during sexual penetration.
Yeah, and the medical term for this specific condition is vulval granuloma fissuratum, or VGF for short.
So to navigate this, we've pulled together a massive stack of rigorous medical sources. We are synthesizing clinical guidelines from the UK, so that's specifically the British Society for the Study of Vulval Disease, the British Association for Sexual Health and HIV, and ICE.
Plus, we've got the European Dermatology Guidelines, Euroguiderm.
Right, alongside some really detailed insights from specialized vulvovaginal disorder clinics spanning from Los Angeles to New York City and all the way down to Melbourne.
And when you look across all those guidelines, a really clear unifying theme emerges. VGF is rarely ever just a standalone issue.
What do you mean by that?
Well, while the physical pain is very real and highly localized, the diagnosis of the tear itself is actually a vital clinical clue. It acts as this glaring signpost pointing to much deeper and crucially treatable underlying conditions that are compromising your tissue's structural integrity.
Okay, but before we investigate those underlying conditions, I think we need to establish what you, as the patient, are actually experiencing physically. Because the sources are remarkably consistent on the clinical presentation here.
They really are.
Yeah, so VGF basically describes the recurrent splitting or tearing of the vulvar skin. And it most commonly happens at a really specific anatomical spot called the posterior fourchette.
Right. So if you picture the vaginal opening, the posterior fourchette is that thin, kind of fork-shaped fold of skin right at the base, like at the 6 o'clock position of the entrance.
Okay, got it.
And from a biomechanical standpoint, it's an area that naturally undergoes significant tensile stress during penetration or, childbirth. The tissue there literally has to stretch laterally to accommodate pressure.
And the sources note that these tears aren't entirely limited to just that one spot, right?
No, not always. They can also occur around the clitoral hood, or in the delicate folds between the labia majora and minora.
And the symptom descriptions we pulled from the patient histories at these specialized clinics are just, they're visceral. Patients describe it as this sharp, knife-like or paper-cut pain that strikes abruptly during or immediately after penetration.
Yeah, and you might see bleeding or spotting along with it.
But the symptom that really jumps out to me is the intense burning stinging when the torn area comes into contact with water or urine or semen.
Which is awful because that specific stinging sensation turns completely routine daily activities, like just using the restroom or taking a shower, into these events of intense anxiety.
I can only imagine.
Because the skin's protective barrier has been breached, right? So it's exposing the highly sensitive nerve endings underneath.
Right. So to make this structural failure relatable for a second, imagine getting a paper cut right on the webbing between your fingers.
Oh, that's the worst spot.
It is. And every single time you try to open your hand to shake someone's hand or, grab a large glass, that cut just rips open all over again. The skin never fully heals before it's stretched and forced to split.
Yeah, it's brutal.
Now, take that mechanical reality and place that paper cut in a highly sensitive, intimate area that is constantly subject to friction and moisture.
That analogy perfectly captures the biomechanics of the condition, actually. Because this skin is constantly being re-traumatized before your body can complete the standard healing process, the tissue enters this vicious cycle.
So it's just constantly trying to play catch up.
Exactly. Chronic inflammation sets in. The body rushes inflammatory cells to the site to heal the breach, which leads to marked tenderness, deep ulceration, and redness. And over time, the body attempts to repair the repetitive damage by laying down scar tissue.
Which importantly lacks the elasticity of normal skin, right?
Spot on. Scar tissue is rigid. By trying to heal the tear with rigid tissue, your body essentially guarantees that the area will lose its natural stretch, making it even more prone to tearing the next time pressure is applied.
Wow. So it literally makes the problem worse trying to fix it.
It does. It becomes a self-perpetuating cycle of pain and progressive tissue damage.
So if the physical reality is this repetitive, agonizing tearing, we really have to ask why it takes so long for patients to get an accurate diagnosis. Because looking at the data, these patients are constantly being told they just have, like, another minor infection.
Yeah, they get completely caught in a diagnostic trap. The misdiagnosis rate here is staggering.
It really is.
Patients presenting with VGF are frequently told they're just suffering from recurrent urinary tract infections or chronic yeast infections. They get handed rounds and rounds of antibiotics or antifungals, which obviously do absolutely nothing to solve a structural, mechanical tearing problem.
Right, which creates this crazy phenomenon of the phantom UTI. The stinging from acidic urine hitting an open fissure feels like almost identical to the urethral burning of a real UTI.
Exactly. But, the confusion isn't entirely the fault of a rushed doctor.
Really? How so?
Well, a comprehensive review in the Indian Journal of Dermatology, Venereology, and Leprology points out that the medical term itself, granuloma fissuratum, is a massive misnomer.
Wait, a misnomer. So it's entirely wrong.
Basically, yeah. It's a complete historical artifact embedded in the terminology, and it actively misleads clinical thought.
Okay, let me unpack this because this is wild. When pathologists take a biopsy of these chronic fissures, they find hyperkeratosis, which is a thickening of the outermost layer of the skin.
Right.
And they also find the canthesis. I actually had to look that one up. It's a thickening of the deeper layer of the epidermis, the prickle cell layer. So the body is essentially building up extra skin layers to protect itself from the constant trauma.
Exactly. It's fortifying the wall.
But the one thing completely absent from a granuloma fissuratum biopsy is an actual granuloma. The review literally suggests that calling it acanthoma fissuratum would be far more accurate.
It absolutely would be.
So wait, why is the medical establishment using a term for an inflammatory mass when there is literally no mass present? Why does this naming error even matter to the patient?
So the terminology reflects how the medical field historically viewed the condition. Early dermatologists compared these vulvar fissures to spectacle frame granulomas.
Wait, like from wearing heavy glasses?
Yes. Those painful, folded, coin-shaped lesions people sometimes get behind their ears from wearing incredibly heavy glasses that constantly rub the skin.
Oh, yeah.
Yeah, so they viewed the vulvar tearing purely as a localized inflammatory mass caused by friction.
So they assumed the tear was just a localized friction burn and completely missed the broader structural failure.
Exactly. And recognizing that VGF is not an infectious granuloma, but rather a mechanical and inflammatory fissure is a total paradigm shift for a clinician.
I can imagine.
Because if a doctor is looking for an infection or a localized friction mass to treat, they will completely miss the structural reality of the skin. The words we use in medicine dictate the treatments we prescribe.
That makes so much sense. If the old granuloma label was making doctors look for infections, recognizing it as a structural tear means they have to stop handing out antibiotics and start looking for what is actually breaking the skin.
Precisely.
And that brings us to the true clinical significance of this diagnosis. It forces the medical professional to ask the million-dollar question, why is this specific patch of skin failing under pressure?
Right, because the fissure is just a symptom. It is the visible consequence of a hidden failure.
Think of it like a stress fracture in the foundation of a bridge. You can keep patching the concrete where the crack appears, but if you don't investigate the shifting tectonic plate or like the eroding soil underneath the bridge, that concrete is just going to keep splitting.
That's a great way to look at it.
So let's look under the bridge. What are the systemic tectonic shifts causing these tears?
Well, the clinical guidelines divide this into primary and secondary fissuring. Sometimes it's primary, meaning there's no underlying skin disease found and the skin is just naturally fragile. But clinically, VGF is most often secondary to major, sometimes systemic, conditions.
Right.
And the first major condition heavily emphasized across all the guidelines is lichen sclerosus, or LS.
Yeah, lichen sclerosus comes up repeatedly in the UK BSHH and BSSVD guidelines. I know it's a skin condition, but how does it physically alter the tissue enough to cause chronic tearing?
So lichen sclerosus is a chronic inflammatory skin condition that's strongly linked to autoimmune disorders. In LS, your immune system mistakenly identifies the structural proteins in the vulvar skin as a threat.
Oh, so it attacks its own tissue.
Exactly. It sends a cascade of inflammatory cells to the area, which vigorously attack the healthy collagen and elastin. As the structural proteins are destroyed, the skin becomes severely thinned out, fragile, and intensely itchy.
And the UK guidelines mentioned a secondary consequence of that inflammation called fusion. What is that?
Well, when the immune system destroys the normal tissue matrix, the body tries to heal the damage. But without the proper scaffolding, it lays down rigid, sticky scar tissue.
Like we were talking about earlier.
Right. And this chronic scarring can cause the anatomy to literally adhere to itself. It manifests as the resorption of the labia minora, meaning the inner lips just flatten out and disappear.
That sounds incredibly painful.
It is. The clitoral hood can also fuse and seal over the clitoris, burying it completely. And crucially for VGF, this scarring drastically narrows the vaginal opening, which is a condition called introital stenosis.
Okay, so if you have a vaginal entrance that has been narrowed by rigid scar tissue, and the remaining skin has been thinned out by an ongoing autoimmune attack, it makes total biomechanical sense that it would tear like wet tissue paper during penetration.
Exactly. And this is why diagnosing the root cause is so vital. Lichen sclerosus causes immense daily suffering, but it also carries a small yet very real risk of developing into squamous cell carcinoma, which is vulvar cancer.
Yeah, the European guidelines mention neoplastic changes. That's the medical term for cells mutating and becoming precancerous, right?
Yes, exactly. The chronic, severe inflammation of untreated LS creates an environment where cells are constantly turning over and repairing themselves, which naturally increases the chance of a genetic mutation leading to cancer.
Wow.
Now, the risk is less than 5%, but leaving it undiagnosed puts the patient in danger. Diagnosing the VGF is often the first step in catching the LS, halting the inflammation, and preventing those neoplastic changes from ever occurring.
So the fissure is the check engine light that points the doctor toward a potentially life-threatening autoimmune condition.
Precisely.
But LS isn't the only systemic issue causing these stress fractures, right?
Yes.
Sources also point heavily to genitourinary syndrome of menopause, or GSM.
Yes. GSM is incredibly common, drastically underdiagnosed, and primarily driven by a significant drop in estrogen levels.
And I noticed the specialized clinics are really careful to note that this estrogen drop isn't strictly limited to menopause. It can be triggered by breastfeeding or certain birth control pills or even cancer treatments.
That's a crucial point. Anytime estrogen plummets, the tissue suffers. Estrogen is essentially a critical chemical messenger for the pelvic region.
What does it actually do?
It tells the local fibroblast to produce collagen and hyaluronic acid, and it triggers blood vessels to dilate, which ensures a rich supply of oxygen and nutrients. When estrogen levels drop, those fibroblasts essentially just go dormant.
So the tissue is literally starving for the building blocks it needs to maintain its structure.
Exactly. This leads to atrophic vaginitis. The skin loses its moisture, its collagen, and its stretch. It becomes what we call friable in medicine, meaning the tissue is so fragile it easily crumbles, tears, or bleeds under even the most minimal pressure or friction.
Right. And the British Society of Sexual Medicine guidelines detail how this estrogen starvation causes the vagina to lose its rugae. I had to look this up because it sounded like a total structural collapse.
Yeah.
Rugae are those natural accordion-like folds inside the vaginal canal that allow it to expand comfortably during penetration or childbirth.
Right. You've got it. When those accordion folds disappear due to estrogen loss, the tissue becomes smooth, pale, and incredibly taut.
Now, there's a really fascinating anatomical nuance here pointed out by Dr. Kleiman's clinic down in Melbourne. They note that the outer vulval skin actually lacks estrogen receptors entirely.
Right.
So if the outside skin doesn't rely on estrogen, why does GSM cause a tear on the posterior fourchette, which is on the outside?
That is such a brilliant observation by them. While the outer labia may lack those receptors, the vaginal opening, the introitus, and the internal vaginal canal are densely packed with them.
So the inside is packed with them.
Right. And the posterior fourchette sits right at the transitional border between the outer vulva and the inner canal. When the internal tissue and the opening lose their stretch and become rigid due to estrogen deficiency, any attempt at penetration puts all the tensile force directly onto that border tissue.
Oh, I see.
The entrance refuses to yield, so the skin tears at the absolute weakest point.
That makes perfect sense.
Yeah.
So we have the autoimmune destruction from lichen sclerosus and the hormonal starvation from GSM. But the guidelines identify a third category of root causes, which is mechanical or pelvic floor structural issues. In these cases, the skin itself might be perfectly healthy, but the surrounding muscular architecture is failing.
Exactly. A classic example is a poorly healed episiotomy or a spontaneous tear from childbirth.
Right.
If the repair heals with thick, rigid scar tissue, that specific line of tissue no longer has the flexibility of the surrounding normal skin. It acts as a tension point, repeatedly splitting at the seam under pressure.
And the clinics also highlight pelvic floor hypertonicity, which is often associated with vaginismus. The muscles forming the pelvic bowl, which surround the vaginal opening, are involuntarily contracted and just super tight.
Yeah, and if those underlying muscles are clamped shut and refuse to yield, any attempt at penetration acts as a wedge.
Oh, wow.
The skin over the muscles is forced to bear the entirety of the pulling force. Even perfectly healthy, estrogen-rich skin will tear if the muscular foundation underneath it is violently resisting the stretch.
Returning to our bridge foundation metaphor, if a patient comes in with this repetitive tearing and the doctor simply prescribes a numbing cream or a warm bath, they're literally just painting over the crack in the concrete.
They really are.
They're completely missing the autoimmune disease destroying the collagen, or the estrogen deficiency starving the tissue, or the muscular spasm pulling the whole structure apart. And the patient continues to suffer, their anatomy might continue to snare and fuse, and they remain at risk for cellular mutations.
Which is why the clinical diagnosis of VGF demands a much deeper investigation. Once that investigation uncovers the root tectonic shift, the clinical team can implement highly effective, targeted treatments. We see a real escalation of care in the guidelines, moving from conservative management up through specialized physical therapy and finally to complex surgical reconstruction.
Okay, let's unpack that treatment escalation.
Yeah.
Because the golden rule across all the UK and European guidelines for first-line treatment is clear, treat the root cause.
Always.
If the stress fracture is caused by lichen sclerosus, you deploy the heavy hitters to stop the immune attack. The guidelines overwhelmingly recommend ultra-potent topical steroids.
Specifically, formulations like clobetasol propionate. The clinical data supporting this is very strong.
Yeah.
Oh yeah, the BSH guidelines reference studies where a vast majority of patients, up to 75%, saw significant improvement with ultra-potent steroids, and over half became completely symptom-free.
But wait, how does a topical cream actually stop a structural tear?
Well, the corticosteroids penetrate the tissue and actively suppress the localized immune response. They essentially tell the inflammatory cells to just stand down.
Okay.
And once the immune assault is halted, the inflammation subsides, the constant destruction of collagen stops, and the body finally has a window of peace to repair the tissue with flexible skin rather than rigid scar tissue.
Now, if the underlying cause is genitourinary syndrome of menopause, steroids aren't going to help, right?
Not at all.
The treatment shifts to localized estrogen therapy. Patients use a cream, a tablet, or a localized ring applied directly to the vaginal tissue.
Exactly. By reintroducing the estrogen directly to those starved receptors, the fibroblasts wake up, they rebuild the collagen, restore the blood flow, and bring back those accordion-like rugae.
That's incredible. But alongside the targeted medical therapy, the guidelines emphasize vital general care to protect the skin barrier.
The foundational skincare protocols are totally non-negotiable. The European guidelines universally advise patients to eliminate all potential irritants.
Like what?
This means stopping all perfumed soaps, avoiding rough panty liners, and abandoning tight clothing that causes friction. They recommend using bland, heavy emollients like just plain petroleum jelly to act as a physical barrier against acidic urine and to trap moisture in the healing tissue.
Okay, but what about the mechanical causes, like the pelvic floor spasms? The specialized clinics heavily utilize pelvic floor physiotherapy.
Yes, but physical therapy in this context is highly specialized. It often involves the use of graduated vaginal dilators.
Now, those aren't just used to physically stretch the tissue, are they? Because it seems from the sources like it's more about retraining the nervous system.
That is a crucial distinction. Dilators are used for neuromuscular retraining. The physiotherapist helps the patient use slowly increasing sizes to communicate with the pelvic floor muscles, down-regulating the stretch reflex.
Okay.
The whole goal is to teach the muscles that they can yield to pressure without pain, stopping the involuntary clamping that pulls the skin apart in the first place.
So we have steroids shutting down the immune attack, estrogen rebuilding the tissue, and physical therapy retraining the muscles. But what happens when the structural damage is simply too severe? When the tissue has scarred over so many times that medications and therapy just can't bring the elasticity back?
That is when the clinical team escalates to surgical intervention. Surgery is considered the absolute final step in the pathway. It's reserved exclusively for cases where the fibrotic scarring has created a rigid, unyielding ring of tissue that medications just cannot reverse.
Here is where it gets really interesting to me, because on the surface, the idea of surgery sounds entirely counterintuitive.
Yeah.
If you perform surgery on an area of the body that is already highly prone to tearing, won't the new surgical incisions just create more scar tissue that will inevitably tear again? How does cutting the skin solve a problem of the skin splitting?
It's a vital question, and it really gets to the core of surgical biomechanics. The goal of these procedures is not simply to excise the fissure and stitch the wound closed in a straight vertical line.
Right.
Because if a surgeon did that, the resulting linear scar would simply contract during the healing process, become rigid, and tear again the moment horizontal tension was applied during penetration. A straight vertical scar is basically the enemy of a horizontal stretch.
So they aren't just cutting out the bad part, they're completely re-engineering the mechanics of the tissue.
Exactly. They are performing advanced structural refashioning. The literature outlines procedures like a perineoplasty with vaginal advancement flap and a highly complex technique known as a double Z-plasty with a VY advancement.
A Z-plasty. That sounds like surgical origami.
It's an excellent way to conceptualize it, actually. In a Z-plasty, instead of a straight line, the surgeon makes incisions in the geometric shape of a Z. This creates triangular flaps of skin.
Okay.
By transposing or swapping the position of those flaps, they fundamentally change the direction of the scar. Most importantly, this geometric rearrangement borrows horizontal tissue to lengthen the vertical plane, actively releasing the tension of the contracture.
Wow.
They disperse the force so no single point bears the brunt of the stretching.
And in a vaginal advancement flap, they're essentially borrowing healthy, highly elastic, estrogen-responsive tissue from inside the vaginal canal, pulling it down and grafting it over the tight, scarred area on the outside.
Right. They excise the diseased, rigid tissue entirely and reconstruct the entrance with flexible tissue. The healthy epithelial skin covers the vulnerable area without any inherent tension. When penetration occurs, the new tissue can stretch naturally without hitting a wall of fibrotic scar tissue.
It's like taking a tailored suit that is just way too tight across the shoulders, cutting open the seam and letting out the fabric by sewing in a flexible hidden gusset so you can finally move your arms without ripping the jacket.
That is a brilliant analogy. It is highly effective structural engineering. However, the European guidelines, Euroguiderm, place a massive critical caveat on these surgical interventions.
What's that?
Surgery only fixes the mechanical structure. It does absolutely nothing to cure the underlying systemic disease. If a patient with lichen sclerosis undergoes a perineoplasty, the autoimmune condition is still active in their system.
Wait, so the immune cells will just travel to the newly constructed surgical site and start attacking the grafted tissue all over again?
Precisely. Therefore, it is an absolute clinical mandate that prior to surgery, patients must be educated on the necessity of continuing their topical treatments like the ultrapotent steroids long after the surgery has healed.
Wow.
The medical treatment must be maintained indefinitely to protect the delicate surgical repair from being destroyed by the original disease.
Bringing all of this rigorous source material together, what does this deep dive mean for you, the listener? I think the diagnosis of vulval granuloma fissuratum, or acanthoma fissuratum, to use the more accurate term, is profoundly significant. Primarily, it provides crucial validation.
Oh, absolutely.
It proves that the stinging, burning agony is not in your head, and it is not a phantom UTI that you are failing to clear.
It interrupts that maddening cycle of ineffective antibiotic treatments and offers a definitive structural explanation for the localized pain.
And beyond validation, it acts as the necessary trigger for a targeted diagnostic investigation. It forces the medical team to look under the surface for those hidden engines of disease.
Right. It points them toward lichen sclerosis, allowing them to intervene and mitigate cancer risks.
It highlights the silent tissue starvation of GSM, allowing for hormonal restoration.
It shifts the patient out of a cycle of silent suffering and places them on a pathway of targeted, effective treatment. Whether that involves specialized immunosuppressive creams, localized estrogen, neuromuscular physical therapy, or complex surgical origami to rebuild the structural integrity of the tissue.
It stands as a perfect clinical example of how a tiny, highly localized mechanical failure can be the master key to unlocking a patient's broader systemic and structural health profile.
It really is a master key.
Well, thank you for joining us on this deep dive. Before we sign off, we want to leave you with one final provocative thought to mull over.
Yeah, this is something that wasn't explicitly in the guidelines, but naturally follows all this evidence.
Exactly. We have spent this entire time dissecting the physical mechanisms, how the skin conditions cause the structural tearing, and how that tearing generates physical pain. But consider the brain's profound role in this chronic feedback loop.
Right.
If you experience sharp, knife-like pain every single time you attempt intimacy, for months or even years, your nervous system is taking notes. Your brain learns to equate penetration with severe trauma.
A powerful, highly protective subconscious association is basically hardwired into the nervous system.
So could the intense psychological anticipation of pain inadvertently cause the pelvic floor muscles to clamp down in a protective involuntary spasm so severely that your brain's defense mechanism is essentially causing the physical tearing to persist?
It's a huge question.
Could the neurological fear of the pain become the very mechanism that keeps the skin splitting, even long after the original underlying skin condition has been completely cured by steroids or estrogen?
It highlights how deeply intertwined our physical structures and our neurological expectations really are.
It really does. Something to think about. See you next time.